afternoon. This study came as an evolution in two challenges that we encountered in an outpatient surgical center. One was the immediate need for a specimen radiograph, and then second was encountering patients where more than one wire was placed for either long segment microcalcifications or multifocal disease, and struggling with the ability to have a three-dimensional picture in my mind from a two-dimensional mammogram. And so a study was proposed comparing the use of intraoperative fluoroscopy compared to just standard techniques. I'll briefly review some of these techniques, discuss some of the potential benefits and potentially comparisons with intraoperative ultrasound, and then look at some of the data for this relatively small sample size. It's really a straightforward technique. It's really hard to see. I'm sure it's a small wire, but the arrow is to help find it. The fluoroscopy is brought in at the time of surgery. Just a brief x-ray is taken, and it's again hard to see from here, but the wire and the clip can be visualized, and then the appropriate markings made for the incision, as well as marking where the track of the wire and the clip went. And as soon as the specimen is removed, we get an immediate specimen radiograph and can make decisions live time. There's no, at least we didn't do it this way, we didn't make any pathologic assessment of the specimen. We just took an x-ray and then based on that finding sent it off. So there's a recent article out of JAMA looking at just regional positive margin rates, and it varied throughout the country from 16 to 26%. The best rates in the mountain regions, Colorado, West Coast. Worst were in the Northeast, New York, Maine, and but varied as well. One thing I want to highlight as well is that after 2014, we switched to a concept where all negative margins were considered sufficient, though prior to 2014, close margins, which were less than 2 millimeters, were often returned back to the operating room for re-excision. Just a brief summary of the data. We looked at 217 cases. Of these, 49 returned to the operating room for a 22.6% return to the operating room percentage. Those did include some close margins. Of the 49, 34 were actually positive. The total numbers for the fluoroscopy group were 88, and the total for the standard group were 129. And you can see at the bottom, just this is just raw data. Then converted to percentages, again based on 88 fluoroscopy and 129 standard. And there was no statistical difference between the two. There maybe was some slight improvement for positive margins with fluoroscopy, though that evened out with a slightly worse outcome for close margins. But again, no statistical difference between the two. We did look at the surgeons who were using fluoroscopy. This tended to be a tool used by the young surgeons, myself included, or those not yet confident in their technique, and so it did help as a bridge. And what we thought was interesting compared to the senior surgeons, that the outcomes were identical, and so it did seem to be a useful bridge. With an expanding bust line in the United States, we also looked to see if body mass index had any impact. There was some slight advantage for the fluoroscopy group with a slightly larger BMI of 30, though again no statistical difference between the two groups. Then subdivided based on which margin was positive. The fluoroscopy can be used 360 degrees, though the anterior and positive margins tended to be the most common positive. The numbers add up more than the 34 that were positive, as many patients had multiple positive margins, either for invasive cancer or DCIS, but anterior and posterior margins were frequently involved. When we further subdivided, looking at residual tumor, the fluoroscopy group had less residual tumor. 47% still had either DCIS or invasive cancer remaining, whereas in the standard group, 67% still had residual disease. Those we've seen a few slides, the trade-off was that the specimen size was a little bit larger in the fluoroscopy group. Again, no statistical difference between the two. It would make sense that the tumors and the positive margins were larger. The median size for the tumors that had positive margins were 3.5 centimeters in size, whereas the overall median size of all the tumors was 1.5 centimeters. Larger tumors had a higher chance of positive margins. This is one aspect of the study where the data was significant. Again, maybe pointing towards the junior surgeons using fluoroscopy, but the volume of the specimen was significantly larger in the fluoroscopy group than the standard group, suggesting that the more senior surgeons were able to be more accurate in their specimen excision. We also looked at the pathologic subtypes, and our best results were invasive ductal carcinoma. The return to operating room was 17%, which was very good. However, most of our data, most of the subtypes where we had to return to the operating room were invasive lobular carcinoma, or DCIS, which is consistent with most of the world literature. And despite all the attempts with better imaging and intraoperative assessment, these two subtypes, I think, will remain a challenge. So in summary, we did find this use of intraoperative fluoroscopy to be a bridge, especially for those early in their career, to assist with optimal negative margin rates. Certainly more senior surgeons will evolve where they don't need it. And we really didn't look at ultrasound, which is increasing in use across the country and across the world, as our initial desire was to find a technique to allow for immediate specimen radiographs. Now, the technique did not improve positive margin rates, but did allow equivalent rates to our more senior surgeons. And again, the technique did not allow significant improvement in anterior and posterior margins, which remain a challenge. The tumor subtypes, as I mentioned, would be, I think, will continue to be a challenge despite the technology used. I do appreciate your time. Thank you.
Dr. McLoughlin, thank you very much. I think everybody is really on time at the end of